Julia Hodson lives alone, but her life is full of people. Today, she's cooking for a community fundraising dinner.
There goes the telephone again.
She serves on 3 boards, 2 commissions, and is an active member of other organizations. She's also a certified professional guardian for elderly clients.
I guess I call myself a community servant.
Often, Julie is too busy to enjoy the view from the deck of her Whidbey Island home. But this week, she has to slow down. Her left carotid artery is severely blocked, and she's on her way to Harborview Medical Center to have it treated.
Once we found that this situation existed, it's something that has to be dealt with, and so it wasn't too hard to make it a priority.
Carotid artery is the blood vessel which supplies blood from your heart onward up from both sides of your neck into the brain. So whenever you have narrowing of the carotid arteries, the blood supply to the brain on that side will be affected. And there are warning signs like she had, where she has transient loss of function. She gets blindness in an eye, which recovers completely. She has numbness in her right arms, and then that clears off. Now that's a warning sign which you have to be wary about, because that's a major predictor for stroke.
25 emails since midnight. Wow.
Julia's many friends are sending emails of support for a positive outcome.
Because we come from so many different cultural backgrounds and religious beliefs, we, instead of what we call prayer, we call it green beams of healing. And I'm getting green beams on me from all over the world today. It's just really, really neat.
Julia's carotid artery is 85% blocked by plaque deposits, so medication isn't a treatment option at this point. But she's a poor risk for surgery due to other health concerns. She was treated for a blocked coronary artery just a few weeks ago.
The problem with Julia getting the surgery is she's had a coronary stent placed less than 6 weeks ago, and she has to stay on a medication which keeps the blood thinner. Now, if you operate with those drugs on board, it can cause some problems related to bleeding. And secondly, she also has active coronary artery disease, so that's classified as a risk factor for surgical procedures. Hey, Julia. Good to see you.
Julia's cardiologist at the UW-Medicine Regional Heart Center diagnosed her condition and referred her to the Center for Endovascular Therapy for a carotid stenting procedure. He felt that stenting, which is a minimally invasive alternative to surgery, would be the best treatment for Julia.
So today again we'll just go probably from your right groin, take catheter up. And then we put a little basket to stop clots from going in when we do your stent. And then we use a balloon to open up the blood vessel and then put a stent to hold it open.
I'm curious to see this stuff before I go to sleep.
Dr. Raj Godke and his team are part of UW-Medicine's Center for Endovascular Therapy.
The Center for Endovascular Therapy is a group of physicians from vascular surgery, cardiology, and interventional radiology that provides a full spectrum of care to patients with vascular disease. So we have people who have a background in surgery or a background in radiology or a background in internal medicine, but all of us overlap in this particular area of image-guided endovascular surgery.
So what does endovascular mean?
I guess the best way to think of it is sort of like operating from the inside. What we do is we use image guidance, sometimes it's CT, sometimes it's ultrasound, sometimes it's x-rays, to find our way to the problem area and fix it from the inside rather than basically cutting the patient open and working on it directly from the outside. So it's minimally invasive, image-guided vascular surgery.
Doctors on the endovascular team see patients at both Harborview Medical Center and the University of Washington Medical Center.
We've tried to integrate the strengths of 4 different specialties who've been traditionally taking care of carotid artery disease. For example, the vascular surgeons, they have a lot of involvement in peripheral artery disease, so they bring a lot of experience from that field. About a third of the patients who have coronary artery disease have carotid artery disease, so they also have cardiac issues which need to be handled, and cardiology has taken a lead in carotid artery treatment, so they are part of our team. And we have interventional radiology, which traditionally has a strength with using stents all over the body. And for us as interventional neuroradiologists, we deal with the carotid and the brain on a daily basis. So it makes sense to have all these players together rather than to have each of us try separately to do this, as is done in most other institutions. So we have a very great team, and we have people participate in decision making during the procedure and in the post-op care.
Are those the films that they made the other day?
Do they have your name there?
Yeah.
At Harborview today, Julia takes a keen interest in her procedure.
Why the extra oxygen?
It helps to monitor your breathing as well. You know, when you get some sedation, what happens is your breathing kind of slows down, and it just helps us monitor, make sure you're safe and breathing well.
Julia will be sedated but awake throughout the procedure, which is often the case with endovascular treatments. No general anesthesia means less risk for patients with multiple health issues. For Julia, there are other benefits as well.
I'm just curious about all that's going on.
So this is a carotid artery coming up from the neck, going onward to supply the brain. So right where this arrow is narrowing, you can see this black thing, that's the plaque. It's full of cholesterol, fatty deposits. What we're trying to do is open it up so that there is enough blood flow without any obstruction.
The stenting procedure Dr. Godke will be performing has been developed over the last decade or so, and it's used in other areas of the body as well.
It's really a natural progression of the original procedures that were done with balloon angioplasty. And actually, when we put stents in, we actually do balloon angioplasty at the same time. That's how the stent is placed. The difference between balloon angioplasty and a stent is a balloon angioplasty opens the vessel up, but a stent maximizes that result.
It's like a spring that's placed inside the vessel and holds it open. In the early days, there was a risk of stroke from the procedure itself, when plaque particles would sometimes travel through the newly opened artery to the brain. Today, a tiny basket filters those particles during the procedure.
A basket is a little filter. It has multiple holes in it, so it allows blood to flow through. But whenever you have pieces of debris from your angioplasty procedure, it will trap them inside. So you can just recapture it and take it out. So it makes the treatment a lot safer.
So Julia, you're going to feel a little pinch down here.
The procedure starts with a small needle in the groin, where a catheter is inserted and threaded up into the neck. The team takes pictures called angiograms of Julia's head and neck. To outline the vessels clearly on the angiogram, a contrast liquid is injected first.
Feel something warm in the lower jaw.
Yeah. That's the contrast.
Oh, okay.
That'll make your face feel a little bit warm.
Next comes the basket on a very thin wire. The basket opens up to catch any stray particles.
Can you give me a 5 by 20 balloon?
The doctors follow it with a balloon to open up the narrowed section of the blood vessel.
Now going up with the stent.
Last to be inserted is the stent, which will stay in place to keep the vessel open.
It stays there, it gets integrated into the body. There's the layer of blood cells that grows over it, it's called endothelium, and it completely engulfs the stent from inside. So you actually have a new wall for the blood vessel, which is smooth and without any obstruction. We're just going to take the filter device up now.
Meanwhile, the basket has done its job of protecting Julia's brain from clots and debris.
After the evolution of this protection device, stroke rates from this procedure are almost equal to or less than that of surgery. Looking good, Julia. How are you doing? Great.
So Julia, I'm going to take some pictures. I want you to hold real still, and that includes, just for this moment, no talking, okay?
Okay, good.
Good.
And you start getting the very bright people involved to develop new technology and new techniques, that this is all migrating to less invasive types of approaches, which I think is better for patient care. I mean, it's a better experience, less potential morbidity, for example, or other problems that occur, and it's much shorter recuperation.
It was perfect. Managed to get a stent in, open up the artery. It looks pretty close to normal. And she did great throughout. She held stable. There was no complications. So we're very happy with the result.
Yep. Piece of cake.
In a few days, Julia will return to her life of never ever just sitting still. She has a camping trip planned for the following week.
I got a lot of life planned. I plan to live it.
Morning. How are you?
Good.
How's your leg?
At the University of Washington Medical Center, Dr. Tori Andrews is preparing to perform a different type of endovascular procedure called vein ablation.
There really is no blood vessel in the body that we can't treat using our techniques. The catheter that we use, which is in some cases not much bigger around than a human hair, can be introduced through any of a number of sites. So right now what I'm going to do is I'm going to look at your leg with ultrasound. We'll map out the course of the vein that we're going to treat. I'll put some ink on your skin just so that we know where to prep it, and then we'll put some cream on the skin that will make it numb.
Today, Dr. Andrews will treat Wanda Alexef's varicose veins. His experience with this is both professional and personal.
I'm not just the doctor, I'm also a patient, having had this done myself. I think everybody knows somebody with really bad varicose veins, painful swelling of the legs and those big ropey vessels that look so bad and can bleed and cause a lot of discomfort.
Normally, blood travels back to the heart from the legs through a series of one-way valves. So when you contract a leg muscle, for example, blood is pushed upward and the valves close behind it. When those valves fail, blood comes back down and pools in the legs, stretching out the veins. There are cosmetic concerns, of course, but seeking treatment is far more than a question of vanity.
Venous hypertension, this reflux condition involving veins, can be really dramatic in terms of the impact that it has on patients. It can cause tremendous pain. It can cause skin changes up to and including ulcers, just spontaneous breakdown of the skin. And in a really severe case, could even lead to a bone infection that would require an amputation. So that's not the common scenario. Usually it's just pain and itching. But it's definitely much more than a cosmetic problem. See the way that lights up? I squeeze your calf, and when I let go, you see all this flow coming back through the vein. That's abnormal, and that's what's causing your problem.
Okay.
Ultrasound enables Dr. Andrews to map out the course of the vein he'll be treating. Vein ablation involves using a laser, which seals the defective vein shut without removing it from the leg.
With vein ablation, what we're able to do is to put a little tiny laser fiber inside that vein and then basically seal the vein closed entirely from the inside. So the whole procedure is done with a puncture at the knee that a couple of days later you won't even be able to find. Patients are able to basically get off the table at the end of the procedure and walk out the door.
Again, Dr. Andrews speaks from personal experience. His own recovery from the procedure was typical.
I had my procedure done on a Friday, and I spent the weekend just relaxing at home and went back to work on Monday. And 2 weeks after the procedure, this was in January that I had it done, 2 weeks after the procedure I was back on the mountain. I was on a ski team at the time, and I was out racing. I didn't do very well, but then I never did. I'm just going to give you a little bit of numbing here, okay? A little stick and a burn.
Before the procedure begins, Wanda's leg is injected with a local anesthetic along the vein.
Reduce the depth. Okay, that's good.
Once again, ultrasound is key to guiding the procedure.
What I'm doing first is just getting a needle into the vein, and once the needle's in, then I put on a little wire. And then the wire serves as my guide for the rest of the procedure. See that bright white line there? That's my guide wire inside the vein. This device is called a sheath, and it actually goes into the vein, and then we put the laser fiber inside it. You can see it's about as big around as a piece of spaghetti.
The laser fiber is inserted next. Before it's turned on, fluid is injected to protect surrounding tissue from the laser's heat.
The bright white line is the laser fiber in the vein, and on the right there you see the thing moving, that's the needle. And what I'm doing is I'm putting the needle right next to the vein and then putting in fluid. And you see how what I'm doing is I'm creating a pocket of fluid around the vein. So let's go ahead and get started.
Dr. Andrews pulls the laser back through Wanda's vein, moving the device 1 centimeter every 5 seconds.
The laser is actually on now, and what it's doing is heating the blood that remains in the vein to a point at which it basically forms a steam cloud, and the steam actually scalds the vein wall, and it's that scalding that causes the vein to scar closed.
All Wanda feels is a little bit of pressure.
That's it.
When the procedure is finished, no stitches will be necessary.
Just checking to make sure that the vein is shut down, and I don't see any remnant of it there, so that looks really good. And all we'll do now is put on a Band-Aid and put on your compression stockings and send you home.
Okay.
See you later.
For Wanda, endovascular treatment allowed her to walk away almost immediately after the procedure. In more severe cases, such as traumatic injuries, these techniques may be the fastest way to treat a critically ill patient.
At Harborview, we see a lot of patients with traumatic injuries to their aorta. When people are in very large automobile accidents, as they stop suddenly when the car stops, often the aorta doesn't stop so well and can be torn in that process. Approximately 85% of people that have this type of an injury never even make it to a hospital. When they do make it to a hospital, they tend to have just had a very large traumatic injury. They're in a very tenuous situation. Oftentimes they have severe injury to their lungs as well, which makes putting them asleep for a big operation very difficult. So these patients are oftentimes ideal candidates for a quick endovascular approach to their injury.
That was true for patient Stephen Lee, the victim of a hit-and-run accident in April 2005.
I believe that I had like 4 or 5 broken ribs and a collapsed lung, and one of the broken ribs cut the main artery out of my heart. And I was told that it was like a bubble on a tire, and if it were to have burst, my heart would have pumped my blood out my body in 2 or 3 seconds.
So after we cannulate this side and we get the pigtail up, we're going to go ahead and get the sheath up.
Doctors at Harborview Medical Center used a stent graft to repair Stephen's torn thoracic aorta. It was the first time this particular device had been used on the West Coast.
They made a couple of small incisions instead of cutting my chest open and inserted a stent, and it's unnoticeable. I don't even know it's there.
Stent grafts are used on other patients to prevent thoracic aortic aneurysms from rupturing. An aneurysm is a ballooning out in the wall of an artery. If it bursts, it's very often fatal.
When treating thoracic aortic aneurysms, I think this is one of the best areas where we can bring 3 different teams together to treat a very difficult problem. The interventional radiologists have a wealth of experience with the imaging itself, looking at the angiograms and interpreting the angiograms, and just working in that environment where you're not doing any open procedures at all. The vascular surgeons have a wealth of experience from treating aneurysms in the abdomen, and a lot of that same experience translates to similar aneurysms and large stents when placed in the chest. The thoracic surgeons, these are the physicians that are usually treating these disease processes initially through operative means. And so they're the best people that can look at these patients and say, this patient needs a stent graft, this patient needs to go to the operating room.
We, in general, consider the disease process and understand what the disease process is, then consider the patient and what their anatomy is, what their underlying medical problems are, and then select the best treatment for them. And I think every patient should be considered with that in mind, because there are patients which open surgical repair is better for. There are patients who probably endovascular repair is better for. And I think every patient should expect to be evaluated with all options in mind.
Placing thoracic aortic stents is basically the same technique as other endovascular procedures.
These devices are usually delivered through the femoral artery in the groin, and they're fairly large devices, and they're put up through a large vascular sheath into the aorta. We do real-time angiograms and basically map out the patient's anatomy, map out their aneurysm or their injury, and then these large devices are basically pushed up over a wire into place in the aorta, and then they're deployed. Once they're deployed, it's basically a matter of pulling a string. The grafts tend to expand on their own, and then we basically gently touch them with a balloon to get a seal for the grafts. After that, we follow that up with more angiograms just to make sure that we've excluded the aneurysm effectively and the graft's in good position.
The size of the stent depends on the area of the body where it will be used. Until recently, no one was manufacturing stents that were exactly right for a thoracic aortic stent graft procedure.
we needed basically short, small stent grafts that were very large diameter that we could use, and there wasn't really anything that was like that in the market. But now there's some better grafts that are out there that are a little bit more tailored to this sort of a problem.
All right.
Very happy?
Yeah.
Looks good.
Pinning.
There he goes.
Not bad.
It was one of those new stent grafts that doctors use to repair Stephen Lee's aorta. Thoracic aortic stent graft procedures are done in a combined interventional radiology suite and operating room. In the few cases where a procedure needs to be converted to an open surgery, the patient won't have to be moved.
Say they have a very difficult aneurysm, which could be treated either as an open procedure or as an endovascular procedure if everything goes well. Where we are with the technology right now, not all devices perfectly fit all patients. So there are some patients that we go in with the idea that there's a very good chance that we will be able to fix this with a stent graft, but if that doesn't work, if we're not able to get a seal around the aneurysm, or if this graft really isn't going to work for this patient's anatomy, some of those patients can be then converted to the traditional open procedure in the same room. This is a pre-procedure angiogram, and here you can see these two large aneurysmal outpouchings from the aorta kind of coming out here and coming out here. And this patient was a very poor surgical candidate. And this is an image after we've placed our stent graft. And here you can see the stent graft itself kind of extends out to line the aneurysm here. And down here you see this now nice curve without this large bulge that was here before.
Fire. Wow.
Before any endovascular procedure begins, factors such as a patient's health, anatomy, and age are considered. Because the Center for Endovascular Therapy includes doctors with a variety of specialties, patients receive the treatment that's best suited for them individually.
If a patient presents with a difficult situation and there's a question about how best to handle that patient, we can get the whole group together and review the case, look at the images, talk about the patient's particular clinical background, and come together as a group with what we believe is the best treatment plan, and then present that to the patient.
We've developed this Center for Endovascular Therapy specifically to bring all of the groups that have these varying skills to the table at once, where we can all focus on these procedures and the patient, setting the egos aside and setting everybody's individual skills into an area where they work best. And again, I think the thoracic grafts are a perfect example where we bring three physicians with widely different approaches to their patients all together, and we're able to focus our energies and our strengths into this new technology.
Stephen Lee has a useful memento of what that new technology did for him, a Gore-Tex jacket from his team of doctors at UW-Medicine.
That's the material around this stent that's in my heart, so I kind of cherish this coat. I had all the doctors sign it for me, so it gives me a little constant reminder, and I need those reminders to be alive and feel alive, and there's a reason I'm here. I don't know what it is, but I try to do my best, that's all I know.